Yeah. Good evening, all respected panelists and all delegates who have joined via this Zoom meeting for today's wonderful webinar, that is a saga of lymphoma, pulmonologist perspective. What we have to do regarding lung in cases of lymphoma whenever it is involving the lung. So I would like to start with two short cases of Hodgkin's lymphoma which got recently detected in one within a span of 1 week. So I will start with that one. Good evening all and welcome you all for this today's wonderful webinar. In that, I'm going to present two cases at first, and those were diagnosed within 1 week of time span, and those were actually lymphoma cases and typical turnout to Hodgkin's lymphoma. And age of those patients, one was male and one was female, that was around 31 to 32 years of age, younger generation that got uh, lymphoma with pulmonary manifestations. So I will go with my first case. She was 31 years old female. Initially, she was presented with outside hospital. She was present with fever, weight loss, dry cough, and dyspnea for 8 to 10 days duration. And outside hospital investigation revealed right middle lobe consolidation on chest X-ray as well as that we found on the HRCT thorax. And along with that, she was having right supraclavicular lymphadenopathy. What was the consistency of those lymph nodes? I don't know exactly because patient came after 6 to 7 months from this initial episode to me. At that point in time, bronchoscopy showed mucopurulent secretions in the right middle lobe, and BAL was tested positive for the Mycobacterium tuberculosis that was detected very stress, and rifampicin resistance. They mentioned it as indeterminate. So on that basis, she was started on first line anti-tuberculosis treatment, and within 4 to 5 weeks, she felt little better in the sense of well-being was also there, along with improvement in little appetite as well as fever was gone. That was main symptom resolution because initially fever was coming daily with that lead. So ATTV was continued for till 6 months, but in between one or two chest X-ray was done. That was actually not showing any improvement. So after 6 months, contrast and CT thorax was advised, and that physician who was treating that patient, he advised to take the ATT for next 3 months. So total 9 months you have to take. But in meanwhile, he thought we should refer this patient to pulmonologist or pulmonary medicine guy. So he referred this patient on 7th month to me, and actually this was the outside CT on the initial when the ATT was started. It was showing dense heterogeneously enhancing consolidation in the right middle lobe and anterior segment of the right upper lobe. And there were enlarged mediastinal as well as right hilar lymph nodes. Patient was referred to our clinic. On examination. She exhibited hardened right supraclavicular lymphadenopathy and a pansystolic murmur, which was unique finding on auscultation of this patient, and that was on right hemithorax, not on the left side. There was no dextrocardia, but she was having pansystolic murmur on that side. So this was the chest X-ray when she came to us. There is a consolidation in right mid zone and lower zone, and which is typically parahilar or paratracheal and paracardiac. So at this point in time, we thought of doing the USG guided biopsy of the right supraclavicular lymph node. Biopsy of the lung mass, which was there. This is CT after 7 months, after 6.5 months of ATT. Actually, it is showing right upper lobe mass lesion. You are able to see this heterogeneous enhancement within that one on contrast enhanced CT. Here you are able to appreciate very typical of the malignancy, that is spiculated margins and in between heterogeneous uh, enhancement on the contrast. This was the CCT thorax report at that point in time. So what was the reason for her right hemithorax pansystolic murmur? Was the uh, this right-sided internal mammary artery, that is RIMA, which was prominent. So that was the reason for her pansystolic murmur on initial finding. And there was mass lesion along with multiple enlarged supraclavicular as well as lower jugular, right axillary, right upper chest wall lymph nodes. So actually, already USG guided biopsy was done, which report was awaited. Meanwhile, we did a whole body PET CT of this patient, which was consistent with hypermetabolic mass in the right upper lobe with the small discrete FTG-avid nodules in the right lung, as described in the previous listing. And FTG-avid mediastinum, right lower cervical, right axillary, and right subpectoral nodes were there. And there was no distant organ involvement. And at that point in time, right histology from the supraclavicular node was awaited. By seeing this CECT thorax initially, it was very vascular tumor, so the biopsy from the main mass was the avoided, and I thought supraclavicular lymph node will give the result. So that's why we went with this one. And this was the final report of this USG guided right supraclavicular lymph node biopsy report. That was actually consistent with the classical Hodgkin's lymphoma. I'm not going into the details of that description given by the histopathologist. So it was a case of classical Hodgkin's lymphoma. After that, she was referred to the medical oncologist and started on the chemotherapy according to medical oncologist. And coming to a second case of today's presentation, this was actually 37 years old male which came with who came with complaints of the dry cough, dyspnea, chest discomfort since last 1.5 months. Was polished by accubation. On examination, his SpO2 was 85% on room air. He was tachycardia. He was having tachycardia as well as tachypnea. On auscultation, air entry was decreased in the right interscapular, right basal, and left basal region as well. So this is first CT of that patient. It is showing full consolidation as well as pleural effusion in the right hemithorax, along with there is a mild to moderate pleural effusion in the left hemithorax also. So these are pure cuts. So initially, because patient was tachypnic, tachycardic, so pigtail insertion after diagnostic tapping in the same setting was done to relieve his dyspnea, and pleural fluid was sent for routine as well as AD as well as cytoblock to rule out the malignancy. So these are the pleural fluid reports of that patient. Protein was 4.64, exudative range were there. ADA was 24, which was negative for the malignancy, but cells differential cell count was consistent with lymphocytosis, which were of around 95%. And cytoblock came after 3-4 days, which was negative for the malignancy. So we thought further investigation is required for this patient. So I did thoracoscopy because she was presented with pleural effusion initially. Thoracoscopy with biopsy was done. But after doing thoracoscopy in the operation theater itself, I thought there is no significant finding for this patient. But some areas were abnormal. From that area, I took the biopsy. And after taking another consent for the bronchoscopy in the same setting, I went with the bronchoscopy of that patient, and there were no significant finding in bronchoscopy also, except extrinsic compression of the right upper lobe as well as right middle lobe bronchi. So biopsy was taken from that area, but I was not satisfied with that biopsy also because nothing was endobronchial in that case. Zidane stain and gene expert was negative for BAL. This was the pleural biopsy, thoracoscopic pleural biopsy report, which was not consistent with anything except this fibrous pleuritis. So again, after this draining of the fluid, I went ahead with the HRCT, CECT thorax of this patient. And here you are able to see this ICD in situ there is a loculated collection along with big mass in the anterior mediastinum of this patient. So this is the report. Whatever we have discussed is mentioned over here. So after this, I thought I took that patient in the UHG and I did screening for that patient. Can we go ahead with the UHG guided biopsy of this patient? Meanwhile, time was going on because all of us know biopsy will take minimum 4 to 5 days. But in between interim report I got that was negative, and I was not happy that something will come positive. So negative mind was there. Along with that, I took that patient in the UHG and screened that patient for the UHG guided biopsy, and it was accessible via UHG guided biopsy. In that same setting, I did the UHG guided biopsy of that patient, and final report of histopathological examination is here. That is again classical Hodgkin's lymphoma, and which cells were positive for the CD30, CD15, and PAX5. So again, this patient was referred to the medical oncologist and started chemotherapy after removal of this ICD, which was put after the thoracoscopy. So thank you for all for your patience listening. We'll move ahead with another presentation. Thank you.
Thank you very much for the kind introduction, Dr. Sahib. And thank you, CCI, for this wonderful opportunity. So the topic of today's webinar is Saga of Lymphoma, a pulmonologist perspective. So lymphoid proliferations of the lung, they are either reactive or neoplastic. So coming to the reactive, and it is very important to differentiate between these two processes, the reactive and the neoplastic processes. So coming to the reactive, they occur in the setting of autoimmune conditions or altered immune conditions like acquired or congenital immunodeficiency, or tissue response pattern to infections such as mycoplasma, chlamydia, EBV, and legionella. There are three main patterns, which includes follicular bronchiolitis, nodular lymphoid hyperplasia, and diffuse lymphoid hyperplasia, which is also called as lymphoid interstitial pneumonia. So here I would like to highlight one point that over the years, in the past few decades, it is recognized that most of these reactive proliferations are actually marked lymphomas. Hence, great caution is required to differentiate between these two processes, and the diagnosis of reactive should be made only after all the necessary studies are done to exclude lymphomas. And these studies, they include the morphological studies, the immunohistochemistry, flow cytometry, and molecular studies like PCR and FISH. So coming to the classification of lymphomas of the lung and pleura, this is based on the WHO classification of lymphoid tissue. We have the primary pulmonary lymphomas and the secondary pulmonary lymphomas. In the primary pulmonary lymphomas, the most common ones are the extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue, also called as MALT lymphomas. And then the second most common lymphomas are the diffuse large B-cell lymphomas. Then we have the lymphomatoid granulomatosis, primary effusion lymphomas, classic Hodgkin lymphoma, post-transplant lymphoproliferative disorders, and other immunodeficiency-associated lymphomas. Coming to the secondary involvement by a systemic lymphoma, these include the low-grade B-cell lymphomas, diffuse large B-cell lymphomas, peripheral T-cell lymphomas not otherwise specified, and the anaplastic large cell lymphoma. Coming to the primary pulmonary lymphomas, these account for less than 0.5% of primary lung cancers, less than 1% of lymphomas, and about 3 to 4% of all extranodal lymphomas. These are clonal lymphoid proliferations. They may affect either one lung or both the lungs in individuals with undetectable extrapulmonary or bone marrow involvement at the time of initial diagnosis. So at the time of initial diagnosis, there should not be any extrapulmonary or bone marrow involvement at the time of diagnosis, and also during the successive 3 months. This primary pulmonary lymphomas, these are grouped into non-Hodgkin's and Hodgkin's lymphoma. Hodgkin lymphomas are very rare, and non-Hodgkin lymphomas are the most common primary pulmonary lymphomas. CT scan is an effective diagnostic method, but pathological biopsy is still needed to confirm the diagnosis, making this a gold standard for primary pulmonary lymphoma diagnosis. The most common specimens which we receive in the histopathology lab for diagnosis of these lymphomas are EBUS FNA samples, the transbronchial biopsies, CT-guided percutaneous needle lung biopsies, VATS biopsies, and resection specimens. So here I would like to highlight one point. It is often very difficult to distinguish reactive lymphoid proliferations from lymphomas and also appropriately classify them on small samples. So the best tissue for diagnosis of a lymphoma and classification of these lymphomas is always a surgical lung biopsy. So coming to the most common primary pulmonary lymphoma, that is the mucosa-associated lymphoid tissue lymphoma, also called as malt lymphomas. Unlike the malt lymphomas of the stomach, thyroid, and salivary gland, the pulmonary malt lymphomas have an inconstant association with infectious agents like H. pylori or any specific immune conditions. 40% of these cases, they contain the translocation 1118, and the imaging study shows solitary or multiple discrete nodules. So this is the biopsy picture of malt lymphomas. This is the low power view. This is the high power view. High power view shows a mixture of these cells, which are small resting lymphocytes, centrocytes, monocytoid forms, and plasmacytoid forms. This is another picture where this is the core biopsy, and the core biopsy, the lung parenchyma is destroyed by the small lymphoid proliferations. These are CD20 positive, and this picture shows CD21 positivity in the follicular dendritic cells which are present in the background. These two pictures, they show the lymphoepithelial lesions. So the lymphoepithelial lesions are nothing but these tumor cells, they infiltrate the bronchial mucosal epithelial lining, and they destroy this epithelial cells, and these are called as lymphoepithelial lesions. And this is the lymphoepithelial lesion, and the CD20 positivity shows these lymphocytes which are surrounding these airways, and they are destroying them. So coming to the immunophenotype of malt lymphomas, these are CD19, 20, 79A, and BCL2 positive, and they are negative for CD5 and CD10. Always you have to look out for the immunophenotypic aberrancies. CD5 positivity is seen in less than 10%, CD10 positivity is seen in less than 5%. If CD10 positivity is more, then you have to suspect a follicular lymphoma. Like CD43 positivity is seen in around 20-22 to 25% of these cases, and this aberrant CD43 positivity is a very helpful marker for diagnosis of this malt lymphoma. Along with that, even clonal restriction of plasma cells, which is seen in 50%, this is also a very helpful clue for the diagnosis of this malt lymphomas. Coming to the second most common, that is the diffuse large B-cell lymphoma of the lung. These constitutes around 5 to 10% of the primary pulmonary lymphomas, and 50% of them, they develop from malt lymphomas. The CT scan shows solitary or multiple nodular masses or an endobronchial mass, and microscopically, they show sheets of large cells with open vesicular chromata and visible nucleoli. Necrosis may be present, and K67 is around 40 to 90%. The subclassification of DLBCL is same as that of WHO classification of DLBL of the other sites. So this is the biopsy picture showing this mass lesion. This is the high power view showing these large cells which have vesicular nucleus and prominent nucleoli. These are CD20 positive, CD10 negative, and MUM1 positive. So this is a diffuse large B-cell lymphoma, non-germinal center B-cell type. Coming to lymphomatoid granulomatosis, this is a rare EBV-driven lymphoproliferative disorder. The primary involves the lung. It can also be seen in other sites like skin, kidney, and central nervous system. It is angiocentric and angiodestructive. This is predominantly composed of reactive T lymphocytes with admits large atypical EBV positive B cells. So based on the number of these large atypical EBV positive B cells, these are again graded into grade 1, 2, and 3 according to the WHO classification. So this is the picture showing the angiocentric and angiodestructive nature of this lymphoma. So this is the small blood vessel, and this blood vessel is surrounded by these tumor cells, and they are also destroying this blood vessel. This is the high power view showing the scattered large cells which are EBV positive. They are also positive for CD30, and they are also positive for CD45 and CD20. Positivity of CD45 and CD20 helps this to be differentiated from the classic Hodgkin lymphoma. Coming to the primary effusion lymphoma, these are large B-cell lymphomas. They usually present a series of effusions without any solid tissue mass. They are universally associated with human herpes virus 8. They occur in patients with immunodeficient states like solid organ transplant recipients and HIV patients, and pleural cavity is the most common site of involvement of this lymphoma. Morphologically, this is a large cell type. They have the large cells, they show either, look like either large cell immunoblastic lymphoma or an anaplastic large cell lymphoma. And immunohistochemistry, according to the IHC, these are very poorly differentiated lymphomas. They are neither T cell positive nor B cell positive, but they show positivity for the plasmacytic markers like CD38, 138, and MUM1. And EBV is positive in around 90% of the cases. So this is the picture of the primary effusion lymphoma in the pleural fluid, where we find these large cells which have this basophilic cytoplasm and this multinucleated nucleus with predominant nucleoli, and some of them shows this perinuclear puff. Coming to the classic Hodgkin lymphoma of the lung, these are very rare, and more commonly it is a direct extension from mediastinal classic Hodgkin lymphoma into the lung. Histologically and immunophenotypically, these are the same as that of classic Hodgkin lymphoma of any other site. So this is the picture showing this parenchymal pleural masses, subpleural masses, as well as intraparenchymal masses. We're showing geographic areas of necrosis. This is the hyper view showing these necrotic areas along with these mummified cells, some large cells which are present, atypical and polylobated. And this is the classic Reed-Sternberg cell with this bilobated nucleus, prominent nucleoli, and abundant cytoplasm. So coming to the immunohistochemistry of Hodgkin lymphoma, these are CD30 positive, they are PAX5 positive, they are EBV positive, and they are negative for CD45, CD20, CD3, ALK negative, and in this case, they are CD15 also negative. So coming to the next, that is the secondary lymphomas of the lung. In our practice, the small bay lymphomas, these constitute the most of the lymphomas that we encounter in our routine practice. So since they are so common, sometimes we may see these lymphomas in the lung biopsies as well. So this is the small lymphocytic lymphoma looking exactly like that of the other sites. They have the small lymphocytes along with that proliferation centers, follicular lymphoma, and then we have this mantle cell lymphoma where this diffuse infiltrate is positive for the cyclin D1 marker. Coming to the T-cell lymphoma, this is rarely an original diagnosis in the lung. There is always a clinical evidence of a systemic lymphoma. Histological features and immunophenotypic features also resemble the T-cell lymphomas of the other sites. Flow cytometry and demonstration of clonal T-cell receptor gene arrangements are very helpful to diagnose these T-cell lymphomas. And true primary T-cell lymphomas of the lung, there are few case reports in the literature, and all of them are associated with HTLV1 viral infection. The most common of these T-cell lymphomas in the lung are peripheral T-cell lymphoma not otherwise specified, anaplastic large cell lymphoma, and extranodal NK-bar T-cell lymphoma nasal type. So this is the picture of the ALK positive anaplastic large cell lymphoma where we find these large cells. And among these large cells, we find also these hallmark cells, which are nothing but cells which have abundant cytoplasm and reniform nucleus. These cells are CD30 positive and ALK positive. So to conclude, the clinical team is increasingly taking an initial minimally invasive approach that yields quantitatively limited biopsy samples. So to not squander material or useless tests, the pathologist managing the case must develop an accurate and tight differential diagnosis on morphology and then be able to effectively use a broad array of immunohistochemistry, cytogenetic, and molecular genetic assays for the final diagnosis. So with this, I conclude my topic, and thank you so much.
So good evening, everybody. We are going to discuss the investigations in this CCI webinar of Saga of Lymphoma. So the investigations of choice for diagnosing lymphoma, we all need to know, and we are going to discuss about it. So before starting about, we should know about the bit of a history of milestones of bronchoscopy. How did we reach from rigid bronchoscopy towards EBUS TBNA? So many hurdles were crossed, so many things were made, so many inventions were done, and we reached to EBUS TBNA. Now the agenda of our talk is going to be discussing the investigations, the procedure, and the literature support for the procedures. So we all know that both neoplastic and the benign lesions that can be presenting as abnormal mediastinal masses or lymphadenopathy, which are going to be diagnosed as lymphomas, and fast and correct diagnosis of such lesions is very necessary. Now talking about EBUS. EBUS right now is the minimally invasive procedure which has revolutionized the diagnostic approach for these mediastinal lesions. It enables the real-time supervision of the TBNA, and it is a very simple and a well-tolerated process and provides the high-quality pathological specimens for the assessment. Now we all know about EBUS TBNA, I think, so that EBUS TBNA is a transbronchial nodal aspiration. We are going to get a step higher. We are going to climb a step higher. We are going to discuss EBUS TBFB. Now, what is EBUS TBFB? It is EBUS-guided transbronchial forceps biopsy. We are using forceps to take the lymph node biopsy, and we are examining the specimens and giving out the diagnosis. So when this EBUS TBFB was practiced, it came out, the diagnostic yield came out to be from 64 to 93% in benign conditions, and overall the diagnostic yield also improved. This is a paper from 2013 that concludes that EBUS-TBFB, it increases the diagnostic yield in benign conditions and may add value in the molecular analysis of lung cancer. Another meta-analysis of 6 observational studies, including 443 patients in whom TBFB was performed after the initial EBUS-TBNA. So after EBUS-TBNA, EBUS-TBFB was performed and the complication rates were very low, and it was a very good alternative for surgical biopsies, and it came out to be 86% positivity for lymphomas and 93% positivity for sarcoidosis. Another paper, EBUS-TBFB, that was recently published data using electrocautery by Barnley et al. And in India, Dr. Ravindra Mehta, he also published a paper on EBUS-TBFB that EBUS-TBNA guided mediastinal lymph node forceps biopsy in patients with negative rapid onset evaluation, a new step in the diagnostic algorithm. And he also was concluded the same. More data is there, 5 papers and literature are present. So what is the method? We do a normal EBUS, we do a normal TBNA, and we push the TBNA needle vigorously to make a small hole. After that small hole is made in the bronchial wall, we push a mini biopsy forceps and take out the biopsy, and we take it out and we just send it for examination. Now, you can see the biopsy forceps which are used for doing the same procedure. EBUS-TBFB, you see the lymph node has been located, and in the real time, you can see the forceps biopsy being taken from the lymph node. Now, another thing that has worked in this era is, after that, EBUS-TBFB, which was providing an excellent diagnostic yield, it still has a scope of improvement because the tissue which was provided to the pathologist, they reported about the crushed architecture, the crushed specimens, the crushed artifacts were there. So another thing was devised, that is transbronchial mediastinal cryobiopsy. So thus for the histological evaluation, this recently developed technique which combined both TBNA and cryobiopsy, and this yields more mediastinal tissue for analysis than the needle aspiration and the forceps biopsy. So the principle, we all know how the cryoprobe works. The gas tip at the tip expands. The gas at the tip expands due to sudden difference in the pressure, which results in the dropping of the temperature at the tip of the probe where the tissue attaches, and this leads to the formation of an ice ball. And we remove it with a tug. The whole assembly is removed, and we take out the tissue, and it is sent for investigation. So this is the equipment that is used. We all know cryobiopsy equipment, the nitrous oxide and the carbon dioxide equipments are available. Different sizes of cryoprobes are available, 2.4 millimeter, 1.9 millimeter. We can see the literary support when the tissue is the issue. The transbronchial mediastinal cryobiopsy in the diagnosis of mediastinal lesions, published by Felix R. Another paper that is published by Dr. Harikishan Gonoguntla. So they all came down to the same conclusion that EBUS-TBNA, then EBUS-TBFB, and now EBUS-TB-CNB. This is the new thing in the era and is being practiced to diagnose the patients of lymphoma and other mediastinal diseases. So you can see the size of the biopsy specimen that was yielded of the cryobiopsy. You can see the size of the specimen. So now how do we practice this cryo procedure? It is ideally attempted immediately after the EBUS-TBNA. The TBNA passage should be done through a single point of entry, and you need to create a tract as this cryo probe is blunt. So sometimes we use a knife, or we use a 1.9 millimeter needle to make a hole, and we locate that hole and we insert the cryoprobe inside. So you need to visualize that entire probe before you activate. Freeze time is around 3 to 6 seconds, and entire scope and the probe, as you know, needs to be removed as a unit. So ultrasound guidance is there, endoscopic guidance is there, we visualize the puncture site and we insert the cryoprobe. Now, conjunction of cryobiopsy and EBUS-TBNA in the same procedure is that does not increase the discomfort to the patient. Again and again, you don't need to perform the procedures. We can obtain the actual histologic samples, and the tumor architecture, the tissue architecture, it is maintained, and you get to have good biopsy samples. The combined diagnostic yield of cryo with EVUS TBNA was 97.4% as published in a paper. So, some points to ponder upon: 19 gauge needle entry point should be there. Use of endoscopic view and also the hemorrhagic line inside the node on ultrasound is visualized. Always, you need to have cryoprobe that is 1.1 millimeter, because the 2.4 won't go in your EVUS scope. So 1.1 is used, and you want to use it in general anesthesia, it is good. It should be done in the general anesthesia. It should be done in the rigid scope. But we can also do it in a fiber optics with a EVUS TBN in a bronchoscopy suite. Pushing saline immediately after 19 gauge puncture, and ensure the tip of the probe is visible and is around the center. So you need to keep the patient safe. You need to keep your scope safe. If you stick inside and you're not able to remove the cryoprobe, you need to stop. You don't need to force the procedure. Just stop, let this ice formation go, and you can remove your cryoprobe safely. So this cryobiopsy has been done in most of the nodes. We should avoid it in case of pus, necrosis, or Doppler, which may show a lot of vessels around it. Minor bleed can be seen, but you don't need to get scared of the bleeding, and you can continue doing the procedure. Some complications such as pneumomediastinum, respiratory failure, pneumothorax are reported. They can be dealt very easily, and cryo is easier than forceps and probably gentler to the scopes. So in conclusion, EVUS TBNA has an impressive yield already. Certain shortcomings in diagnosis of benign disease and lymphoma are addressed by this technique. In malignancy, better samples may help in molecular studies. This is a complementary technique. It is not a competition. It complements each other. This forceps biopsy, cryobiopsy, it complements your EVUS TBNA. ROSE is highly desirable and may increase the bronch duration, but it improves the diagnostic yield of your procedure. So you give the patient what you promised him, and you give the patient the diagnosis in his hand in your first go. Thank you.
A very good evening to all fellow CCI colleagues. Thank you, Krishna sir, for this kind opportunity. Thank you, Aditya, for that very relevant approach to the diagnostic armamentarium for lymphoma. Now, coming to potential complications that we might come across, of which one complication which definitely needs special attention is febrile neutropenia. I am Dr. Ravi Dosi from Indore, and I would like to talk in concise about febrile neutropenia, because in itself, I think this is a webinar to do. Now, well, I started off preparing febrile neutropenia, and I came across this very interesting patient education slide. But this patient's education slide, if you have a look at, actually inculcates the whole of my presentation. What is febrile neutropenia? Where do we see it? Well, the causes are bone marrow disorders, sepsis, tuberculosis, hepatitis, chemotherapy, particularly cytotoxic agents, and autoimmune diseases. Common presentations will be if you have a history of any of these conditions and you are febrile, if you are having mucositis, mucosal ulcers, or GI ulcers, or you are having non-specific abdominal pain, then the patient should be alerted about febrile neutropenia. Usually on investigations, we look that there is a fall in neutrophil concentration and the total leukocyte count. The MASCC risk index is most important, in which we look for the symptoms which I have mentioned: hypotension, presence of COPD, solid tumors or hematologic malignancies with no fungal infections, no dehydration, burden of febrile neutropenia with moderate symptoms, whether the patient is an OPD or IPD presentation, and if it is the patient is an elderly, more than 60. So lesser the score, the more is the particular risk factor in this particular situation. Now, who are those who are at risk for febrile neutropenia? Patients, cancer patients on cytotoxic chemotherapy, as the cytotoxic therapy affects myelopoiesis, It affects the integrity of the GIT mucosa. It predisposes to high risk of infections. It can also be seen in patients who are in the pre-engraftment phase of hematopoietic cell therapy and induction therapy for acute leukemia. Neutropenic patients usually suffer from this because they are unable to mount a robust inflammatory response, resulting in serious infections with minimal symptoms and risk. Fever is usually the only telltale sign of infection, and this particular infection is rapidly progressive, which may even cause septic shock. Now, the fever will be defined as a single oral temperature of more than 101 degrees or 38.3 degrees, or a fever of more than 38 degrees sustained over an hour's period. On examination, an ANC count of 500 to 1000 with less than 500 ANC count being considered severe if over 48 hours, profound if it is less than 100 cells per microliter. And we should be very careful that if the ANC count is less than 100, then the risk of bacteremic infection rises considerably. So, if a patient presents to you, then initially we have to assess by taking a proper oral body temperature. Oral body temperature is said to correlate with the absolute neutrophil count. The timing of the febrile episode is very important, whether it is 2 weeks following the dose of chemotherapy. We should remember that 70% of febrile neutropenic patients will present within 4 to 6 weeks. It is recommended in the guidelines to use a tympanic thermometer. Accurate measurement of temperature is of prime importance in the diagnosis of febrile neutropenia. Now, if the patient is undergoing anti-cancer treatment and is at the risk of neutropenic sepsis, first of all, the moment they become unwell, we should suspect it. For adult patients, we should consider a count of around 500, and we should start prophylaxis with fluoroquinolone during the expected period of neutropenia only. The rates of antibiotic resistance and infection in that particular area, or like in our country, with the prevalence of tuberculosis, we should be very careful while initiating fluoroquinolone prophylaxis. It is very important that routine colony stimuli fattening factor should not be advised in these patients. We should first evaluate as to what is the cause of that low neutrophil count. If it is an infection, then we need to be aggressive with our antibiotic therapy. So you initially proceed with a history, do a full blood count, your KFTs, RFTs, C-reactive protein, lactates, send a paired blood culture. And after carrying out, you also do an additional blood culture in patients with a central venous access device, if clinically feasible, to rule out any catheter-related sepsis. You do urinalysis in all children aged under 5 years. And the one thing is there that they have recommended not to perform an X-ray unless clinically indicated. But as all of us are pulmonologists in this, I would personally prefer that X-ray be the first thing that we do. But again, recommendation doesn't ask for it. Now, we should treat it as an acute medical emergency. See, this is an acute infective attack and offer immediate antibiotic therapy. We should offer beta-lactam monotherapy with piperacillin tazobactam with suspected neutropenic cases, and we should try to avoid aminoglycoside either as mono or dual therapy unless there is a specific indication, because nowadays most of the isolates are gram-positive cocci, so we should suffice with using a piperacillin tazobactam. When the patient is having a central venous access, there is no need to remove it immediately. We should not offer glycopeptide antibiotics like vancomycin to suspected neutropenic patients as an MRSA cover as per guideline recommendation. Now, what do we do further? If we confirm that there is a high temperature, there are signs correlating with sepsis, we have confirmed neutropenic sepsis, then we go in for assessment, whether this is a patient who is at low risk of complications or high risk of complications. So again, whenever we look for the risk factor, the MASCC risk index for neutropenic fever scores come in. We look at the burden of illness, whether there are mild symptoms, which has more weight, no hypotension, more weight, COPD, no COPD, more weight, solid tumor or no previous fungal infection, more weight. But if the patient has an age less than 60, outpatient status, burden of illness, moderate symptoms, then you keep on getting lower scores, and the lower the score as I is 21, then it is a higher risk of the patient gathering more sepsis or severe sepsis because of neutropenia as compared to patients who manage to gather a higher score. Now, if the patient has undergone this particular risk assessment, you find that he is low risk, then you go in for quinolone prophylaxis. If the patient is having high risk or septic shock, then you proceed with imipenem or meropenem if the patient is having colonization or infection by cephalosporin resistant Enterobacteriaceae in the last 90 days. If there is no such history of septic shock, then you can very well start with either injectable piperacillin tazobactam or cefepime or ceftazidime. Whenever a patient presents to you with neutropenic fever, the septic screen should include 2 sets of blood cultures, early antibiotic therapy within the first 60 minutes. If the patient is febrile at the end of 48 hours, then you can consider addition of vancomycin. And if the patient is febrile at the end of 4 days, you should consider addition of antifungal therapy. Who are the patients who are really high risk? ANC less than 500 for more than 7 days, a mask risk index score less than 21, a CISNE score of more than 3, presence of any active uncontrolled comorbid medical problems like septic shock, oral or GI mucositis, GI symptoms like abdominal pain, nausea, vomiting and diarrhea, intravascular catheter infection, especially catheter tunnel infection, if there is a new pulmonary infiltrate or hypoxia which has set in, if there is underlying chronic lung disease, if there is complex infection at the time of presentation, if the patient has used LM-tuzumab or CAR-T cell use within the past 2 months, if there is uncontrolled or progressive cancer, and if there is evidence of hepatic insufficiency. Now, these are some pictures which I could get from a close medical oncologist friend of mine. Ichthyoma gangrenosum should be identified as it is an early indicator of Pseudomonas aeruginosa infection, which is again carrying a very bad prognosis. And when we were in COVID, we were all afraid in the second wave of mucormycosis, the very infamous black fungus. So we should look for that particular black ischar-like sign in these cases, and it may be an indicator of disseminated mucormycosis. Some other dermatological manifestations are erythema multiforme, or you can have fusarium lesions over the cuff. Now, as bronchoscopists, the primary point of interest for us is if we may do a BAL. If we do a BAL, what all should you send it for? If you are suspecting bacteria, send it for a gram stain and an aerobic anaerobic culture. If you are suspecting molds, then do a KOH preparation, do a silver stain if PCP is suspected, send for a fungal culture. Aspergillus, galactomannan antigen and PCR can be sent as per merits of the case, but please do remember that if you have started piperacillin tazobactam like antibiotic, then galactomannan may come as false positive also. If you are suspecting for an endemic fungi, then look for KOH preparation and send for a fungal culture. Definitely do a histoplasma antigen. If tuberculosis is suspected, and even if it is not suspected in our highly endemic area, please do send for a AFB stain and a gene expert or mycobacterial culture. If PCP is suspected, send a fluorescein conjugated monoclonal antibody. PCR techniques are available. For nocardia, do a modified AFB culture and do a culture in which you should talk to the microbiologist to look for nocardia. As far as viruses is concerned, now a rapid fire viral panel is available. You should look for CMV, influenza, parainfluenza, RSV, adenovirus, human metapneumovirus, HSV, VZV, and Middle East respiratory syndrome virus. You should send it for a cytology to rule out any adherent malignancy. This is a very busy slide, but I would just like to make you concentrate on the right arrow. These are all the things that you are supposed to do in the first 60 minutes of the case presenting to you. You should treat febrile neutropenia as an acute medical emergency and give it the most and surmost of your attention. For prophylaxis of these patients, they should be advised a neutropenic diet, general hygiene measures like rapid hand washing and avoiding exposure to diseased people, bacterial prophylaxis with fluoroquinolones, which again I say with a pinch of salt, antifungal prophylaxis for invasive fungal and PCP should be considered. Antiviral prophylaxis for influenza, varicella zoster, herpes or CMV may be considered, and colony stimulating factors may be given. With this, I would like to end my presentation on one of the potential complications of lymphoma treatment, and at the same time I would like to thank respected Parvez sir and Krishna sir, and on behalf of CCI invite you all for the 5th CCI Con at Srinagar on the 8th and 9th of June. Thank you.
Thank you very much, sir. This was not actually pan after the dinner, but it was very short and sweet dinner which we have given this evening. So first of all, thank you, NH Krishna sir, who is the Sarthya power this CCI, and all CCI officials for this wonderful webinar. And without any stop or without any restriction, it is happening every Thursday. So after this 3-4 presentations, I would like to introduce our today's esteemed panel. We have got 2 special guests today. One out of those is Dr. Sharada Nagoti, who is actually working as a thoracic pathologist in the Hyderabad. Welcome you, madam, for this CCI webinar.
Thank you, sir.
Then Dr. Sushant Mittal, who is medical oncologist, who is working in Delhi. After that, I would like to invite our Ravi Dosi sir, who is very good person as well as very good academician. I just 1 minute I will tell one incidents regarding him. Actually, when COVID was started, that was I think 2020 March something. So I was not one company was asking me for lecture on the COVID, but nobody was knowing at that point in time much regarding this COVID. I put the message and sir gave me this wonderful presentation, PowerPoint presentation. With that presentation, I did 2 to 3 lectures for company people. So thank you very much, sir, and welcome you for this today's webinar. After that, I would like to invite Dr. Yogesh Jain, who is working pulmonologist in Ranchi. Dr. Aditya Chawla, who works in New Delhi, and currently is somewhere in Kolhapur for some marriage party, but still he has joined.
Back in Delhi. I'm back
Thank
in
you
Delhi,
very
sir.
much. Thank you very much for
Right
joining
now
us.
Yeah. Thank you.
Yeah. And Dr. Joydeep Ganguly, sir, welcome you. He is from Murshidabad. Welcome you for this today's wonderful webinar. And with this brief introduction of all our panels, I would like to know some of my doubts regarding this lymphoma from each and everybody of you. So my first doubt is regarding this, how to subtype different types of lymphoma. I would like to know this answer from Dr. Sharada. Over to you, ma'am.
So basically what we do is whenever we get the sample, we first do the morphological evaluation of the biopsy sample under light microscopy. So morphologically, we try to evaluate whether it is a lymphoma or whether it is something else like an epithelial malignancy or a sarcoma or a melanoma. So once we make the morphological diagnosis, then we go ahead with the special studies. And special studies, most of the labs use immunohistochemistry for the typing of these lymphomas. First is to confirm the diagnosis of lymphoma and then to classify. So based on the morphology, we do the different markers, IHC markers like B-cell lineage markers or T markers or monocyte markers or plasma cell markers, and then we type these lymphomas. And some labs, they use the other technique, that is the flow cytometry technique. But in this flow cytometry, the tissue has to be sent fresh, not the formalin fixed tissue. A fresh tissue has to be sent in a special tissue culture medium, that is the RPMI medium, and then it is sent for flow cytometry. So the advantage of flow cytometry is that accurate classification of the lymphomas can be made and multiple markers can be used simultaneously. But the other disadvantage is that the pathologist should make sure that the cytoscreen has the definite tumor cells or the lesional cells. So this is how we do the typing of the lymphomas.
Okay. Thank you, ma'am. Thank you. You are the only people who are actually helping a lot for any pulmonologist or thoracic surgeon as far as these reports are concerned. We are doing our works, we are taking biopsies and sending to you. But if there is no good pathologist or good, there is no experienced pathologist, we won't get the answer to that patient's disease or whatever he is suffering from. So pathologist as well as pulmonologist, actually that is always better combination. And if good pathologist is there, we'll go ahead more in patient care management. So I would like to know from Sushant Mittal sir, what could be the pre-treatment workup for pulmonary lymphoma cases? Could you brief on this one, sir, please?
So lymphomas, in particularly, not particularly pulmonary lymphomas, for any lymphoma, we need to do a basic workup of CBC, LFT, KFT, viral markers, uric acid levels, calcium and phosphorus. And then we need to do a PET scan so that we are able to do a biopsy which is guided and we do not hit a necrotic area, and we try and hit the FDG avid area and we get the diagnosis in the first shot itself. Also, the IHC, as been told by the esteemed pathologist, is very important, and definitely pathologists are the backbones on whom we are able to work. So adequate tissue sample is required. Not only an FNAC, but a biopsy is required so that IHCs and molecular studies can be done. Many a times still we do get an FNAC, and that is insufficient to further categorize whether it's Hodgkin lymphoma or non-Hodgkin lymphoma. So adequate tissue biopsy is required. And then we also require a bone marrow aspiration biopsy for the completion of the staging workup. In cases of Hodgkin lymphoma, when we give bleomycin, we need to have a baseline pulmonary function test and an echo, because we have to give adriamycin to know whether the baseline parameters are normal or no, and we can, on that basis, we can decide the doses of the chemotherapy.
Okay. Thank you very much, sir. Tissue is the issue. So good tissues, each and every time it is required for the lymphoma subtyping as well as planning for the next management of any patient. Yes. Thank you very much, sir, for your brief regarding this one. Now I'd like to come to Dr. Joydeep Ganguly. Sir, can you brief regarding this different radiological manifestations of the pulmonary lymphoma?
Definitely. So lymphoma can present with a varied radiological manifestation, and it's actually a huge topic. So I will talk it shortly. So if we divide it into three parts, that is the mediastinal lesions, the parenchymal involvement, and the pleural involvement. So if we see the mediastinal lesions are more common seen in Hodgkin's lymphoma. First of all, I would like to point out that there could be two types of lymphoma. First is the primary pulmonary lymphoma associated with the bronchoalveolar associated lymphoid tissue, or bialytoma, or like a myeloma, and other is the secondary lymphoma originating from either Hodgkin's or non-Hodgkin lymphoma. Now, if we see the mediastinal lesions, it will see as an asymmetrical mediastinal masses or associated with hilar lymphadenopathy, which is more common in Hodgkin's lymphoma. About 85% of Hodgkin lymphoma presented with mediastinal masses, and also non-Hodgkin lymphoma, though they are more extranodal and extrathoracic lesions are more seen. Again, they can present with the mediastinal lesions. And in case of Hodgkin lymphoma, if we see, the involvement are more in the case of anterior and superior mediastinal. So we can see in the CT that the involvement of the anterior and superior mediastinum is more. Whereas in non-Hodgkin's lymphoma, they also involve the posterior mediastinum and paracardium. Now we'll come to the parenchymal disease, which is also can be different. So first of all, the we have this bronchovascular or lymphadentic appearance. So it is most common in the in Hodgkin lymphoma due to direct invasion from the lymph node by the bronchopermeable lymphatics. And also we can got nodular lesions. So nodular lesions may be evenly nodular, or maybe oval, or maybe spiculated, or maybe in different characteristics. And it is more common in non-Hodgkin lymphoma, and it is present bilaterally. And the position may be any other thing like subpleural, parenchymal, or perihilar, and also some plaque-like mass also can be present. Then again, the consolidation is another form which can appear in the lymphoma. The consolidation or pneumonic alveolar filling opacities are there. Also, it can be segmental or lobar, unilateral or bilateral, and often patchy radiologically indistinguishable for bacterial pneumonia. And in there, a very important sign we can see that is called a CT angiogram sign. What is CT angiogram sign? We can see the vessels traverse through a airless part of the consolidated lung that is very distinct. We can see in either adenocarcinoma or in the lymphoma. And also we can get hematogenous spread, and it gets, in that case we can have multiple bilateral diffuse miliary opacities like miliary tuberculosis or lymphangitis carcinomatosa. So in that case, this is also seen. So in a nutshell, we have this parenchymal involvement by bronchovascular appearance, by nodular, by consolidation, and by miliary. Then again, lastly, the pleural. Now the pleural is also very important because pleural effusion, we have this primary effusion lymphoma mostly in cases of immunocompromised patients, and we can have dissemination from either from the pleural lymphatics, or it can cause by compression of the pleural lymphatics and cause transitive pleural effusion in case of Hodgkin's lymphoma. And most of the case we have also can have chylothorax and also pyothorax associated seen. So yes, this is the main thing. And also if we see in case of non-Hodgkin lymphoma, various other places we can see like abdominal involvement is more than 60% cases of non-Hodgkin lymphoma, and also brain involvement can be seen. And if it is associated with leukemia, we can we know that many myeloid leukemias and like chronic leukemias sometimes converted into lymphomas. In that cases, we can also see some paraspinal mass that can cause severe oncologic emergencies also. Thank you.
Thank you, sir. Thank you. Actually, as far as pulmonary lymphoma is concerned, it can behave like anything. So it will be very difficult to come to the conclusion. Like my case, I have presented. She was actually on ATT for 6.5 months, and finally she was diagnosed to have Hodgkin's lymphoma. And surprisingly, she was not having any distant organ metastasis. That was the luck of her, we can say. So with this, I would like to come to Dr. Aditya. Can you brief on pyothorax associated lymphoma, Dr. Aditya Chawla, please?
Yes, sir. Pyothorax is occurs as the fluid collection in the pleural cavity during pleuritis, and it is mostly seen in those kind of cases which have been made an artificial pneumothorax of post-tubercular cases, old. Then second type of cases are the pleuritis in cases of pulmonary asbestosis, and third are those patients who are having Epstein-Barr virus. So these pleuritis cases, these on PET scan, they have a very high uptake of FDG and need to be managed same as any empyema. But the prognosis in these kind of patients is very poor. So the patient expires when he has these kind of pyothorax in lymphoma within 1 year. But chemotherapy gives a little bit of relief to the patient, a little bit conclusion.
Okay. Thank you very much. Actually, it was happening. Pyothorax associated lymphoma will happen actually in the chronic suppurative pleuritic kind of patients, and there will be lymphatic lymphoid cell transformation in the pleural cavity itself, and that will lead to the development of lymphoma. Thank you, Dr. Aditya. Now I would like to come to Sharada ma'am. Ma'am, can you brief on how to differentiate between reactive and neoplastic lymphoid proliferation on biopsy sample? Please, ma'am.
So the lymphoid proliferations can be either reactive or neoplastic, as I've already mentioned in my talk. So these reactive, and it is very important for the pathologist to differentiate between these reactive and lymphoid proliferations. So first, how do we do is we can do it either morphologically. There are certain soft clues, and again with the use of immunohistochemistry markers. So morphologically, there are certain clues which point towards neoplastic proliferations, like presence of lymphoepithelial lesions, presence of follicular colonization, then a polyclonal, the plasma cells, and the presence of Dutcher bodies in the plasma cells, and pleural infiltration. All these are certain clues which point towards neoplastic proliferation. Whereas coming to immunohistochemistry, again, this has to be again confirmed with immunohistochemistry. So a range of markers can be used like CD3, CD20, 21, IgD, and kappa and lambda plasma light chains. So all these, so presence of these IgG, very clear, crisp mantle zone, which is positive for IgD, along with germinal centers, which are rich in CD20 positive and BCL6 positive B cells, interfollicular regions which are present, which are positive for CD3 positive T cells, and polyclonal plasma cells. So these are all the IHC markers which are point towards reactive lymphoid proliferation. So positivity of all these markers, they are more in favor of reactive lymphoid proliferation. So this is how we can differentiate between these two, morphological clues as well as with the help of immunohistochemistry markers.
Oh, thank you, ma'am. Thank you. So ISC is very important, I think.
Very important for confirmation.
So I'd like, after this, our doubt got clear regarding this differentiation. I would like to come to Dr. Joydeep Ganguly. How to differentiate between primary pulmonary lymphoma and metastatic lymphoma, which is getting involved into the lungs, or lung is getting involved in metastatic.
Yes, sir. Very important question, because primary pulmonary lymphoma is actually represents a monoclonal lymphoid proliferation affecting the lungs in a patient with no detectable extrathoracic lymphoma for at least 3 months. So there is a criteria. So for primary pulmonary lymphoma to happen, there must be that is located only on the lung, and there should be no associated hilar or any mediastinal lymphadenopathy. And it is very rare, because there are no such, like there is less amount of tissue in this bronchial associated lymphoid tissue, like in the gut we have maltoma, but in bronchus we don't have so much of lymphoid tissue. So the way there is any reason, there is a clonal proliferation that occurs in primary pulmonary lymphoma. So the incidence is very less than 1% of total lymphoma cases occurring in the lungs, whereas the secondary pulmonary lymphoma almost invariably present with any other site, like in case of NHL, first the external site, then comes to mediastinal site, and then it can involve any part of the lungs. And also in HL, most of the cases they start with the mediastinal, because the intrathoracic disease is more common in Hodgkin's lymphoma, and it is associated with any pleural or parenchymal lesions. If we see the incidence, the primary pulmonary lymphoma is most commonly seen in either middle age to elderly, whereas in non-Hodgkin lymphoma and Hodgkin lymphoma has can be seen in young and adolescents, and also in the elderly patients. If we see the radiological signs, as this is occurring on a single piece place, most commonly it is presented with a nodule or a mass without any associated mediastinal hilar lymphadenopathy, whereas in case of secondary pulmonary lymphoma, we usually see like mass or pleural involvement or any kind of nodules, which is usually associated with hilar and mediastinal lymphadenopathy. If we see about the mainstay of therapy, as the primary pulmonary lymphoma is more or less localized disease, the main outline of therapy should be surgery to cure, cut off the mass, and then we can go for radiotherapy or associated any other thing. So the prognosis is usually good in primary pulmonary lymphoma in compared to secondary pulmonary lymphoma, where there is a disseminated disease and we have this chemoradiotherapy, but the options of surgery are less. And also another thing is consideration is also more clearly seen in primary pulmonary lymphoma radiologically, whereas this is less common in secondary pulmonary lymphoma. So that's the difference. Thank you.
Thank you, sir. So actually, primary pulmonary lymphoma has good prognosis compared to this metastatic lymphoma in the lungs. Thank you. So after this one, I would like to know from our Ravi Dosi sir, chest wale from Indore, types of lymphoma that has more predilection for the pleural effusion.
Well, basically, we more of non-Hodgkin lymphoma cases tend to involve this pleural, tend to present with pleural effusion. Almost 20 to 30% of all pleural effusions in non-Hodgkin lymphoma patients have pleural effusion as a presentation. It is very rare in Hodgkin's disease. Particularly T-cell lymphomas will involve the serous fluids more. And if you look at primary lymphomas of the pleural cavity, then like Dr. Aditya had told, that pyothorax associated lymphoma PAL, secondary to EBV disease, which is very common in tuberculosis patients, and one another primary lymphoma is seen in HIV, primary infusion lymphoma. This is also very common and primarily involving the pleura. So almost in 30% of all NHL cases, but as a secondary involvement, we get pleural effusion, and pleural effusion helps because we can easily tap it out and understand the cytology and IHC on its basis. But presence of pleural effusion in lymphoma always is a bad prognostic marker.
Thank you, sir. Thank you. So actually presence of pleural effusion, and it is actually very difficult to diagnose also by pleural fluid, as I have seen in 2 cases recently. Pleural fluid, we won't get anything unless and until there is a tissue diagnosis or tissue biopsy. Thank you, sir.
Can I make a point here, sir? Dr.
Yeah,
Sushant
please.
Mittal.
Please, sir.
So regarding pleural fluid, in kids, in children, we have T lymphoblastic lymphomas. They usually present with mediastinal mass, with pleural effusion, and they have very high TLC. So they have acute presentation and they present with acute breathlessness in your OPD. And when you see such kind of kids, you really want the diagnosis really fast. So when I was in TMH, Tata Memorial, I had few 13-year-old, 14-year-old kids who presented to me with this, and we did a diagnostic tap of the pleural fluid and send it for flow cytometry. And I would request my pathologist on the panel also to comment on that. And we were lucky to have a diagnosis within 2 to 3 hours on the flow cytometry of the pleural fluid and start the treatment and save life of the kid. So in in adult lymphomas, yes, it is pleural effusion is most of the time symptomatic and we do not get any malignant cells. But in pediatric population, T lymphoblastic lymphomas, the pleural effusion is quite significant, and the time is not at your hand, then you can do the pleural fluid flow cytometry.
Okay. Thank you, sir, for your excellent addition into that one.
I completely agree with you, sir. Definitely flow cytometry is a time saver here. Another point here I would like to make is when the pleural fluid is sent for differential count and the lymphocytes are more, that itself is a clue to suspect lymphoma in such patients, especially when the clinical and the radiology is pointing towards lymphoma. The presence of this in the differential count, more number of lymphocytes, like as in your case, 95% of lymphocytes.
Yes.
So that is one clue which is pointing towards a suspicion of lymphoma.
Okay. Actually, it will go towards tuberculosis also, lymphocyte predominance. So,
but that amount of, it can be seen. But again, that is why I have added clinically and radiologically if you are suspecting. Of course, even the morphology also, if the pathologist is skilled at seeing the morphology, even the morphology also, these are not like the normal lymphocytes which we see routinely in the tuberculosis patients. These are atypical lymphoid cells.
So that is actually pathologist to actually that skill, or you can say their job to inform respected pulmonologist whoever is there. According to that, we can go.
Yes.
So by flow cytometry, we can. So availability, this flow cytometry, how it is? Every pathology lab will have this one, or
most of the big labs have this flow cytometry, and most of the big labs are doing this flow cytometry on blood, on these lipid samples. But tissue for flow cytometry, like very few centers have this
that is what
tissue flow cytometry.
Constant of this one availability is the issue over there.
Yeah.
After this one, pardon.
For a tissue flow cytometry.
Yes. Thank you. I would like to come to Dr. Yogesh Jain. Sir, what are the primary effusion lymphomas? Can you elaborate on this one?
Good evening, sir. Primary effusion lymphomas are large B-cell lymphomas, which are commonly seen in the immunocompromised, especially the HIV patients with very low CD4 counts and solid organ transplant patients. It is associated with HHV8, and there is also Epstein-Barr virus positivity also seen there. And these are serous effusions, and no detectable masses can be seen. Only these are presenting as effusions.
Oh, thank you, sir. Thank you. Dosi sir, namaste. Again, I would like to come to you regarding one question. What is the mechanism of pleural effusion in lymphoma? Can you elaborate, please?
If you will have enlarged,
Yeah.
if you have enlarged lymph nodes, then they will directly impair the lymphatic drainage of the pleural cavity, and that leads to accumulation of pleural fluid in the pleural cavity. You can have again a direct pleural infiltration by the tumor, which can be either primary or secondary, as we have discussed. There can be compression causing venous obstruction and in turn back pressure causing pleural effusion. Then can be thoracic duct obstruction. This thoracic duct obstruction can cause pleural effusion, even chylothorax can happen in such cases. And some of these lymphomas also release some mediators like vascular epidermal growth factor or vascular proliferation factors, which causes vascular leak. And that also leads to pleural fluid accumulating in the pleural cavity.
Thank you, sir. Vascular leak as well as obstruction and lymphatic infiltration are the most common causes for this development of pleural effusion. And actually, it is one of the bad prognostic signs for our pulmonary lymphoma cases. So, again, I would like to come to Yogesh Kumar, sir. Sir, what are the types of lymphoma? Those will mimic like tuberculosis and will get misunderstood as a tuberculosis.
So you started with the two cases, and both of them were looking like tuberculosis. So Hodgkin's lymphoma, that is most commonly because the clinical features are similar. There is weight loss, there is lymphadenopathy, and fever, low-grade fever is there. So symptoms-wise also it mimics tuberculosis. And also when certain times biopsy is not done and FNAC is done, and they are misreported as tuberculosis because of the mixed cellular mixture, you get all the lymphocytes and other cells, which can very well be seen in TB as well as Hodgkin's lymphoma. So Hodgkin's lymphoma in clinical practice most commonly mimic as TB, tuberculosis.
Thank you. Thank you. And I think that cyclical fever, which is called as also called as Pulmonary fever, that is also one of the pathognomic of this lymphoma. And in my case, actually, that was misleaded the physician because fever was gone. Actually, she might be having minimal, means actually early stage tuberculosis also. That my BAL for MTB gene expert, which came trace positive, and that treatment of that patient went into different direction. So after this one, I would like to know from Sharada ma'am, what is your expectation when the we are sending sample of a lymphoma suspected cases to you, pathologist? So what is pathologist expectation from the pulmonologist or anybody who is doing biopsy and suspecting lymphoma and sending?
That's a very important question, sir. So, so whenever we are getting a sample with a suspicion of lymphoma, certain things definitely as a pathologist, I would need from the clinician, whoever is sending me, on the test request form. So apart from the clinical details like age and sex, the other clinical details which I will need is history of any connective tissue disease or history of any viral infection, both of them pointing towards more of a reactive lymphoid proliferations. Then the other points like history of any transplant, because to differentiate from a post-transplant lymphoproliferative disorder, then history of any prior therapy or a chemotherapy, history of any immunodeficiency. And apart from that, I will also need the CBC picture as well as the bone marrow, if it is done, the bone marrow investigation reports, just to know that whether it is a primary lymphoma or whether it is a secondary lymphoma. These are, and along with it, I will also need the radiological findings, and also whether there are multiple lymph nodes involved or only single lymph nodes are involved. What are the lymph nodes which are involved? So these are all some of the things which I would request the pulmonologist to give the information to the pathologist when the sample is sent with a suspicion of lymphoma. So along with that, I will also need the serological investigations for if there is any serology to be which they have done for connective tissue diseases. So these are some of the points which important points which I would like to know from the pulmonologist on the test request form.
Okay, thank you. Radiology, you have mentioned, yeah, that is very, very important.
Yeah,
Whenever
very important.
even a lot of time I have got calls from the histopathologist saying you send the radio imaging of this patient.
So this clinical, radiological and pathological correlation is very much important, even in the diagnosis of lymphomas.
Yes, ma'am. Thank you, ma'am. Thank you for your nice info on this one. Sir, Dosi sir, again, I would like to come to you. I would like to know from you that what are the causes of hemoptysis in lymphoma cases? Please.
Well, I actually tried to find out any exclusive causes, but I was not able to isolate any exclusive causes to lymphoma. But the general causes which I could find was that usually hemoptysis happens by either rupture of the pulmonary or the bronchial artery system. So the three general mechanisms which can happen are a lung infarction can develop due to compromised blood supply to a particular area. There can be extreme vascular engorgement causing compression of that particular area and hemoptysis subsequently. Locally, any one area can become very hyperemic and result in hemoptysis, or there may be secondary formation of aspergilloma or fungal cavities in those areas affected by lymphoma causing in hemoptysis.
Thank you. Thank you. So with this one, we will come to treatment of lymphoma cases, and I would like to know from Sushant Mittal sir, what are the treatment differences between the different types of lymphoma, lung lymphoma or pulmonary lymphoma cases? You can brief on within a couple of minutes.
So it depends on the type of lymphoma we are treating.
Yes.
So Hodgkin's lymphoma has to be treated with four drug therapy. That is, the most common is ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine. Adriamycin has to be given with caution that echo needs to be fine, and bleomycin with a caution that pulmonary function tests are normal. And in NHL, that is non-Hodgkin lymphoma, if it is B-cell lymphoma, the most common is diffuse large B-cell lymphoma, DLBCL. We give rituximab, that's a anti-CD20, along with CHOP therapy. CHOP stands for cyclophosphamide, doxorubicin, oncovestin is vincristine, and prednisolone. And if it is T-cell lymphomas, then just the CHOP therapy is given, rituximab is not given. All these therapies are given for at least 2 to 3 months. After that, a repeat PET scan is done to see what is the condition, how much the patient has responded, and accordingly we decide for the further treatment. After completion of about 6 cycles, a repeat PET scan is done to see if any residual disease is there. If residual disease is there, then we give radiotherapy. If it is not there, then nothing needs to be done. So this is a brief outline in which we treat most of the lymphomas.
Thank you, sir. In continuation to this question or this issue regarding treatment of different types of lymphoma, so most of the time, this medical oncology, they will ask for the spirometry prior to the starting any chemotherapy. So, what do you expect from spirometry, and what will be your means? Are you going to change the management of that patient? Because most of the time, this patient with pulmonary lymphoma, they will be having different pulmonary manifestation. Like there will be mass lesion or pleural effusion, sometimes unilateral, bilateral. So if they're going to do PFT or spirometry at that point in time, there will be restrictive defect as well as obstructive defect. Both can be combined, or the patient will be getting only restrictive defect and they are quite ill, so they are not able to perform the spirometry with full enthusiasm also because of the underlying disease. So what is your expectation from medical oncologist point of view before starting chemotherapy? And bleomycin, would you prescribe for such kind of patients after seeing spirometry alone?
So it all depends on the condition of the patient. Definitely, if it's a mediastinal mass or uh, uh, a pleural effusion is there, then definitely PFT cannot be performed adequately by the patient, and we have to take the history if the patient has COPD, asthma, is he a smoker. So on all these parameters, we decide on the dosing. If there is no smoking, no asthma, and still the patient has poor PFT because of the disease itself, then we have no issues, or we don't have any hesitation in giving bleomycin. We go ahead and give bleomycin. However, in patients who have axillary lymph nodes, cervical lymph nodes, or and they don't have any mediastinal lymph nodes, and then also their pattern, the PFT is showing that they have restrictive pattern. So we are little skeptical of giving bleomycin in such category of patients.
Okay. Thank you, sir. Thank you. So spirometry is must, but it should be interpreted with pretty much caution, considering the underlying lung pathology in these patients.
Yes.
Thank you, sir. Now I would like to know from Dr. Aditya Chawla, is there
Yes,
any
sir.
necessity of pleural tapping therapeutic patient with primary pulmonary lymphoma, or maybe metastatic involvement of pleural effusion, malignant pleural effusion?
So doing thoracocentesis, it helps relieving the symptoms. That is, so we know. Second thing, post chemotherapy, there are kind of infections that patient catches, so you may get the patient having empyema or pyothorax. So evacuating that pleural cavity is always a benefit to the patient, benefiting in the symptoms and also protecting him from the post chemotherapy infections.
Thank you. So to prevent development of some empyema in such, if underlying fluid is there, and if it is moderate to massive, then we should go ahead with the therapeutic tapping before starting any chemotherapy.
Right.
So with this one, I would like to come for one question open for all. Chylothorax in lymphoma. So what are the chances of getting chylothorax in lymphoma, and what are the causes of that one? And what could be the treatment point of view? Just brief regarding this one. Anyone can take this question.
Well, I would just like to share that I told there is thoracic duct obstruction usually, which can be caused because thoracic duct is maybe involved in the mediastinal lymph node involvement with lymphadenopathy. So if that pressure can result in chylothorax evolving in such patients. And usually you need to drain the first, most important is you need to drain it off. And once you drain by doing an intercostal chest tube drainage, subsequently, some cases may benefit from drainage itself, but it will be a prolonged drainage, and you might need surgical repair also in some cases. Although by the time lymphoma cases present with chylothorax, their general condition is already considered to be very poor. So they are very poor surgical candidates.
Next. Thank you. Thank you. Son, after all our discussion, I would like to know regarding this prognosis, overall prognosis of different type of pulmonary lymphoma cases in a brief from Dr. Yogesh Kumar.
Hodgkin's lymphoma has a good prognosis, and the prognosis depends on the stage of the disease also, because stage 1 and 2, after adequate treatment with the chemotherapy, the 5-year survival rate, overall survival rate is almost 90 to 95%. Hodgkin's stage 1 and 2. Whereas stage 3 and 4 of Hodgkin's, the survival is around 80%. In the non-Hodgkin's lymphoma, slightly lesser survival rate is there. So with the adequate treatment, stage 1 and 2 non-Hodgkin's lymphoma has a survival of 80 to 85% 5-year survival rate, whereas stage 3 and 4 non-Hodgkin's lymphoma has 60 to 70% survival rate.
Thank you. My one question from my side, that is my question to all, that anybody can take this question. Tumor lysis syndrome and its management in as far as this lymphoma cases, pulmonary lymphoma is concerned. Tumor lysis syndrome. Mittal sir?
Yes, sir. So
tumor lysis.
tumor lysis is a medical onco emergency, and usually it happens in high grade lymphomas such as primary mediastinal lymphomas, Burkitt's lymphoma, T lymphoblastic lymphoma. And it happens because as soon as we give dexamethasone or chemotherapy, the tumor cells just break down and they release lot of potassium. And that potassium, along with high rise of uric acid, causes disharmony. Uric acid tries to block the kidney, and potassium tries to cause arrhythmias. And there is in initial 1 or 2 cycles it happens. So it is very important that we give modified doses and take an anti-TLS prophylaxis, which includes lot of fluids along with soda bicarb, and we give Xyluric and Febutas. If patient is in TLS, we give rasburicase. Even 1 ampoule of rasburicase is magical, and patients respond so beautifully to rasburicase that we are able to save lives. So TLS is one thing which in the first year of our residency it is taught, and till now I am teaching my students that TLS and febrile neutropenia, as one of my esteemed colleague was talking about febrile neutropenia as a medical emergency. TLS is also a medical emergency which needs to be taught and learned properly as how one should treat it.
Is there any role of steroids, or corticosteroid or methylprednisolone in this TLS?
So TLS is caused by steroids. We don't give for treatment of TLS. The dexamethasone causes a lysis of tumor cells. So even before blood transfusion, if we give efcolin or hydrocortisone, one has to be aware that we need to give a lot of fluids and we need to take anti-TLS measures so that the kidneys are not blocked.
Thank you very much, sir. Thank you. With this one, we will come to end of our today's webinar. So at the outset, I would like to thank again to CCI family and NH Krishna sir and all CCI officials, Dr. Hatri Gangopadhyay, who has also helped to prepare this webinar proceedings initially. And with good output discussion today, we will take leave, and good night to everybody.
Toke Sahib, a big compliment to you. There are total 959 people watching us all across CCI. So you deserve applause. You have moderated it excellently. And
thank you very much. Thank you very much.
Means really each of the panelists have done exceedingly well. Yeah. Thank you, Toke Sahib. Thank you.
Thank you. Thank you. Thank you all.
Congratulations, Toke sir. Congratulations.
Congratulations.
Thank you, Aditya bhai.
Thank you.
Thank you all for you.
Thank you, sir,
for joining this wonderful webinar, and we have come to the end of that. Good night.
Good night. Good night, sir.